There are key differences in the management of diabetes in older adults, one being an individualized glycemic target. Typically, an A1C target of 7.5 to 8.5 is generally recommended, depending on the patient's functional status and life expectancy. Secondly, older adults benefit from a simplified medical regimen to improve adherence and reduce the risk of error and hypoglycemia. Third, we want to do regular assessments and reassessments. Diabetes in older adults is not just about glycemic control or blood sugars alone. You want to reevaluate cognitive function, risk of depression, frailty, and physical abilities. Monitoring blood sugars in older adults is very important, but the frequency depends on the medication regimen that they're on, as well as their cognitive and functional status and the treatment goals. For those on intensive insulin regimens, then blood sugars should be checked at least 4 times a day before meals and at bedtime. For those with type 2 diabetes who are in long-term facilities, blood sugar monitoring can range from twice a day to every 3 days, depending on the complexity of the regimen and the risk of hypoglycemia. CGMs should be implemented and highly recommended to all patients on an insulin regimen to improve glycemic control as well as to decrease the risk of hypoglycemia.
While glycemic control is important in older adults, we really want to balance the risk of hypoglycemia, which is a bigger risk in older adults for 3 main reasons. First of all, there's increased vulnerability due to decreased renal function, which can impact the metabolism of drugs and can also cause specifically insulin to kind of linger longer. Secondly, due to polypharmacy and comorbidities, this can kind of blunt the patient's typical response to hypoglycemia, so it can go under-recognized. Thirdly, cognitive and functional decline can make it harder to identify and report low blood sugars, which can lead to falls and further functional deterioration. So how can we balance glycemic control while preventing hypoglycemia? First of all, we want to set looser targets for patients who are at a higher risk of having hypoglycemia, who are more cognitively impaired, less independent. Next, we can select safer medications for our patients. So we want to avoid any medicines that we know cause hypoglycemia, specifically sulfonylureas and insulin. Obviously, sometimes we have to use these medicines, but if we can avoid them, we try to do that. Next, we want to monitor glucose levels at home and also educate our patients and caregivers on how to identify hypoglycemia and what to do in the case of hypoglycemia. And lastly, we want to optimize lifestyle factors. So this could be as simple as standardizing meal times, having kind of consistent caloric intake throughout the day.
For older adults with diabetes, especially those with comorbidities such as heart disease and renal disease, there are certain medications that offer distinct benefits in terms of efficacy and safety. Metformin remains to be the first-line therapy for older adults with diabetes, especially since it's very well tolerated and its use is safe. SGLT2 inhibitors such as empagliflozin and canagliflozin are recommended for those with heart failure and chronic kidney disease. They have shown to decrease hospital admissions for heart failure exacerbations and slow down the progression of CKD. GLP-1 receptor agonists such as liraglutide and semaglutide are beneficial for those who are at high risk of cardiovascular disease and aid in weight loss management without increasing the risk of hypoglycemia. DPP-4 inhibitors, such as sitagliptin and linagliptin, are also very well tolerated in older adults due to their neutral effects on weight and their minimal risk of hypoglycemia. And lastly, pioglitazone can help with glycemic control, but should be monitored closely and used with caution due to the increased risk of fluid retention and heart failure exacerbations. Diabetes in older adults is not just about the numbers. It's about prioritizing a safe, effective, and practical management approach.